So, how accurate the glucometer value should be? So, what is the essential parts of the glucometer or glucose strips, or what are the potential errors while doing the SMBG's values? I will be discussing. So, why blood glucose testing is very important? It is a very essential tool for people with diabetes, particularly type 1 gestational diabetes patients, and people who are taking insulin, or people who are having a fluctuating blood glucose. It's very essential for the patient. It helps in knowing whether the values are too high or too low, or it's a normal, and it also helps in managing their lifestyle according to the fluctuation in the blood glucose after exercise or after.
Welcome, sir.
Thank you, sir. Thanks for the kind introduction. So, the topic given to me is self-monitoring of blood glucose in GDM. So, how to ensure quality and reliability. So, I will divide my talk into two parts. One is the glucose monitoring in gestational diabetes mellitus or diabetes complicating pregnancy, why it's important, so what are the targets and how frequently we need to do. And second part of my talk is regarding the glucometers. So, how accurate the glucometer value should be. So, what is the essential parts of the glucometer or glucose strips, or what are the potential errors while doing the SMBG's values? I will be discussing. So, why blood glucose testing is very important? It is a very essential tool for people with diabetes, particularly type 1 gestational diabetes patients, and people who are taking insulin, or people who are having a fluctuating blood glucose. It's very essential for the patient. It helps in knowing whether the values are too high or too low, or it's a normal, and it also helps in managing their lifestyle according to the fluctuation in the blood glucose after exercise or after food. For our healthcare professional, it's essential because based on the values we can start the medication or change the medication, and also we know how effective medications we are giving, how they are responding. So, from the both patient perspective and physician perspective, it's very important. So, what are the targets in gestational diabetes? So, the fasting and preprandial blood glucose should be less than 95, and 1 hour should be less than 140 milligram per deciliter, and 2 hours less than 120 milligram per deciliter. For diabetes complicating pregnancy, slightly different. So, I'm not going to detail in that. So, in that the preprandial should be between 70 to 110, and the postprandial should be less than 2 hours should be less than 110 to 140, and 2 hours should be less than 120. So, how frequently we need to test? So, in gestational diabetic patients, initially on nutritional therapy, or the people who are taking insulin, it's always better to do at least 4 points per day, that is before breakfast, and at 1 hour or 2 hours after the beginning of each meal. So, 1 hour postprandial measurement is preferable because it closely mimics the insulin peak after giving the rapid acting analog, insulin analogs. So, it's always better to measure 1 hour. And we should know that if it's 1 hour, then the target is 120. If it's a 2 hour postprandial, it's 140, or if it's 1.5 hours, it's 130. And all the results should be recorded in the glucose log along with the dietary information. Why postprandial is monitoring is preferred compared to the preprandial? Because most of the studies have shown that postprandial monitoring and control of postprandial glucose levels compared to preprandial monitoring leads to better glycemic management, HbA1c 6.5 versus 8.1, and lower incidence of large for gestational age newborns, 12 versus 42. So, almost 1/4 reduction in the events, and lower rate of LSES birth for cephalopelvic disproportionate, 12% versus 36%. So, controlling postprandial glucose is very important. That's why in GDM, postprandial monitoring is preferred. And coming to the testing in diabetes complicating pregnancy, that is already pre-existing diabetes, there we advise for usually 7 points, because in this kind of patient there will be large fluctuation in the blood glucose. So, fasting and before each meal, and 1 or 2 hours after the first bite of each meal, so 6 times plus bedtime. And additional testing is indicated in selected patients like suspected nocturnal hypoglycemia. So, again glucose assessment between 2 to 4 am we need to do if we suspect nocturnal hypoglycemia. It's always better to document hypoglycemia before initiating intervention. So, inform the patient if they have symptoms, do the SMBG, and then take some food. And CGM may also help in identify the nocturnal hypoglycemia. Dr. Anish has already discussed about that. And coming to pre-breakfast hyperglycemia, if the glucose assessment we are doing between 3 to 5 am before the pre-breakfast, if it is consistently high, then we need to evaluate why it's high. So, it may be due to inadequate insulin management, or the patient may be taking excess carbohydrate snack at the bedtime, or we are giving too low dose of very low dose of basal insulin. If the patient is taking pre-mix, and if you increase the dose, there can be midnight hypoglycemia, and if you decrease the dose, the fasting pre-breakfast hyperglycemia can be there. So again, we need to again modify the insulin regimen, etc. And it could be the dawn phenomenon because of the increased release of counter-regulatory hormones in the early morning. There can be pre-breakfast. So again, we need to adjust the insulin dose. And hypoglycemia again can happen at pre-breakfast level. So then we need to reduce the insulin dose or increase the carbohydrate snacks at the bedtime. And third thing is settings of increased situational risk for glucose derangement. That is before starting exercise or after having hypoglycemia, whether we need to document whether the patient has normoglycemia or during the steroid therapy, etc. We need to monitor more frequently. Whether the frequency of self-monitoring can be reduced, particularly in people on nutritional therapy. They are not taking insulin, they are on nutritional therapy, whether we need to ask them to do 4 points testing daily. So what data has shown is there is no strong evidences for people only on nutritional therapy in patients with GDM. So data has shown that if the GDM is very mild, that is the glucose elevation is only within 5 to 10 milligram from the target range, and there is no signs of fetal overgrowth or increased estimated fetal weight, a normal amniotic fluid volume, doing alternate days testing or reducing the frequency improves the quality of life of the patient. And there is a studies also in patients on GDM or nutritional therapy, if the values are within the range, they compared with the people who are doing daily SMBG versus alternate day SMBG, their birth weight and frequency of macrosomia are all almost similar. So the frequency of testing in patients of nutritional therapy can be reduced, but if the patient is on insulin, it's better to follow the routine regimen. So coming to second part of my talk about the blood glucose meters. So mostly we don't discuss about this topic. So we all know that glucometer measures capillary blood glucose. So now all these glucometers are modified such that it gives the plasma equivalent values rather than the whole blood glucose values. So mostly available glucose meter and the venous plasma glucose method in the laboratory should be comparable. I will come to that in the later. And they should meet the standards compared with those set by the IOST, the International Organization for Standardization, or US FDA. So what are the variables? Again, I will discuss in the future slides. And many current glucometers are reasonably accurate, plus or minus 10%, and require a very small drop of blood. So what are the criteria for selecting the blood glucose meter? So there are various criteria. So accuracy. So we have two types of accuracy, analytical and clinical accuracy I will be discussing, and blood glucose meter and strip technologies, and design and features. What are the additional features the glucometer if we have, it will make the life easy for the patient, and how these glucometers avoid the potential interfering substances. So last thing is obvious, availability in the market. So it should be easily available for the patient, and the strips should be easily available for the patient at reasonable cost. Those things mandatory. So coming to accuracy, again, it's very, very important. Accurate blood glucose monitoring are very, very important because it is essential for monitoring, and we are going to make changes based on the blood glucose values. So for safety purpose also, it's very, very important. So for reliable monitoring or making informed therapeutic decision, accuracy is very, very important. So we have two types of accuracy. One is the analytical accuracy. Analytical accuracy means how closely a blood glucose reading matches the true value. So the true value may be the already established method of testing, like measuring venous plasma glucose by the routine biochemistry testing, and they do the comparison along with the blood glucose values. So they do this random error, which tells about precision, systematic error about the bias, and other interferences like altitude, hematocrit, and galactose. So this first is analytical error. Second is the clinical accuracy. So this is again plotted in the POX consensus error grid. So if we are going to make a decision based on the blood glucose values, this should be in the A or B. So A or B means if we make a clinical judgment based on the reading, there should be no effect on the clinical action. And B is little or no effect on the clinical action. And the variability is very much C or D, it could have more effect, the wrong effect in the treatment. So the patient, we may treat the patient wrongly, and if it E means it can have a dangerous consequences. So always this clinical accuracy of the glucometer has to be in the A and B. So these are all things which will be done while manufacturing itself. They will analyze with the standard method of testing, and they come out with this, what is the analytical error and what is the clinical accuracy, etc. Then only they proceed with the marketing. So there are again guidelines for this, how this method should match with the standard error. So to be make it simple, mostly this FDA and ISO values are similar. if the blood glucose values is less than 100, the difference between the blood glucose meter range and the standard value should be plus or minus 15 milligram per deciliter. And if the blood glucose value is more than 100, then the difference should be less than 15%. So the FDA has told if they are able to do this plus or minus 15 milligram per deciliter less than 100 or more than 100, 15%, then it's almost 95% accurate. And if this same thing is around 20 milligram per deciliter less than 100 or more than 20% more than 100, then almost 99% accurate. But what most of the standard glucometer company, they do before releasing these batches, they target for 10%. That is less than 100 milligram, 10% difference from the standard method, and more than 100 milligram per deciliter, 10%, and less than 100 milligram, 10 milligram per deciliter difference. So they target for more stringent criteria, then only they release this one. But while in the market, at least they should follow this 15 milligram less than 100 for blood glucose less than 100 and 15% more than 100. So we can expect a difference of 15% between the lab value and the glucometer value. Many of our patients ask, so that's the difference between the glucometer value and this one. So you can explain them. If the values are more than 100, the difference can be up to 15%, it's acceptable. And the values are less than 100, it is plus or minus 15 milligram per deciliter. It's acceptable range. And most of this glucometer should also have adjustment for the variation in the hematocrit. And most of the, again, newer glucometers or advanced glucometers have the adjustment for hematocrit between 10 to 65%. And also they should have this, should take care of these interferences like bilirubin, other interfering medications, etc. They should be taken care of. So coming to glucose strips, again, before we used to have this batch to batch variation and require calibration, coding, etc. But now things has changed. Most of the glucometers, there is no need for coding. But again, we need to explain to the patient if the glucometer has to be coded for every batch, then it has to be done religiously. Otherwise, they will be getting wrong report. That has to be told. And nowadays, many strips are packed in groups. But errors are leaving the lid off for a period of time with exposure to heat, moisture, and humidity that can affect the value of the testing. Use of expired strip and mixing the lot of different strips in one can for convenience, again that can influence the reading. And coding, if the patient forgets to do the coding, again it can have different values. And more fortunately, most of the newer glucometers have taken care of this potential errors. So now it's very, very convenient for the patient. They have to just insert and do the testing. And method, GDH based method is better than the glucose oxidase method. I'm not going to detail. So coming to blood glucose device, so there should be no coding. It should be very simple, accurate, and extensive safety checks should be there before releasing the product. And nowadays, again, they can see the patient can see the previous 7, 14, 30, 90 days testing average. Now even they are giving this time in target also based on the previous 2-3 months reading. The glucometers automatically is giving the time in range values also. And it should be very sleek and modern design, easy to handle. And the strips also, the size should be big, where they are going to keep the sample. It should be user friendly, and they should take minimal amount of blood for the capillary blood for the testing. So again, these are the small things, but it matters because elderly patients, if they are having difficulty in doing the test, if it's very convenient for the patient, it's easy for them. There are a lot of interferences, as I told, humidity, if they are keeping open, the temperatures, air, all those things can influence us. And hemodialysis, and particularly if the patient is on peritoneal dialysis, the presence of maltose can falsely give higher values of blood glucose values, so we should keep in mind. And the patient is taking vitamin C, acetaminophen, again those can also influences the blood glucose values. Hyperbilirubinemia, many glucometers, again bilirubin value can influence the blood glucose values, particularly in the patient's neonatal hyperbilirubinemia, we have to think about that. So the bilirubin value can interfere with the glucometer values. So these are the potential errors to summarize. So failure of test strips appropriate to the meters. Again, one different brand they give me a strip they may be using for the different glucometer. Dirty meters, improper storage of the test strip, poor skin preparation. Again, after eating, taking some food, the food particles are there. If they are not wiping out properly, again that can also lead to false readings. So proper skin preparation, and to avoid, we have to avoid expired strips, and we should always remember some interferences can be there, like acetaminophen, ascorbic acid and all. If the patient is in ICU, dopamine infusion again can interfere with the blood glucose values. Oh, sorry, this slide is not so. What can be done? So it's always better we can ask the patient to bring the glucometers to the clinic. So if there is a doubt, we can always cross check with the blood glucose meter what we have in our clinic, or with the standard blood glucose measuring method. And if the values are way out of the thing, then we can do calibration. So we can ask the company fellows to do the calibration. They will have the testing liquid for doing the calibration, so they can do the calibration. If the glucometer is not calibrated for quite some time, we can do the calibration. And every time we can ask the patient how they are doing the test, whether the strip method is what they are using, how they are using is good. And also we need to see that their glucometer log, whether they are maintaining it properly, rather than just asking them what was the reading 1 week back, 2 weeks back. It's always better to see the log, and also see the glucometer, whether they have set the time, hours and all correctly. If they have not setting the timing, time, hours correctly, again we can have a different reading, which are readings which are not matching with the what time they are doing. For example, fasting if they are doing, but the time is not set, then when we are seeing the glucometer, we may get a wrong information. So all these things we need to check. So always better to ask the patient to bring the blood glucose meter and verify it. So the summary, blood glucose monitoring is very, very essential for the patient's perspective also, physician perspective also. And presently available blood glucose monitoring are very much advanced, as less interferences, no coding required, and the accuracy is very good. So they usually target for very stringent accuracy, almost plus or minus 10 milligram per deciliter if more than 100, and 10% if it's less than 100. And operational errors are very common. Again, we need to discuss with the patient what they are doing and try to avoid these operational errors. And patient education is very, very important. Thank you.
Thank you, Dr. Shanmugasundaram, and it was very